I'm Dr. van der Bijl, presenting neonatal resuscitation, which is the first part of Lecture 1. The Perinatal Problem Identification Program is a program where each and every death file in the neonatal period is audited in order to establish the main causes of death for neonates as well as avoidable factors. So it's important to note that the pattern in a developing country like South Africa will be very different from what you can expect in developed countries. So in South Africa, our babies still die of prematurity, asphyxia-related disease, and septicemia. And it's clear that if you can resuscitate a premature baby or an asphyxiated baby well, that you will improve their morbidity and decrease the risk for mortality. This is also true for septic babies in the ward, that if you manage them well in the beginning, they will have a much better outcome. Neonatal resuscitation is an evolving science. It was only in the 1990s that they realized that neonates needed their own guidelines. Updates are forthcoming every 5 years, and this is based on the latest and newest evidence of how to support a baby to make this transition. The talk is based on the American Heart Association's Advanced Neonatal Life Support course. So do remember that when you do ACLS, APLS, there's also an ANLS course. Things have changed very much from the olden days, Dr. Schultz's method, to what we are doing today. And it's very important to stay abreast of the newest developments. When we talk about neonatal resuscitation, it's important to just take a step back and consider the very important transition that neonates have to undergo from the fetus intrauterine, where the mother is supplying in all the baby's needs, to the extrauterine life, where the newborn now has to start breathing, has to change the cardiovascular system from fetal to a neonatal circulation, and to also start with thermoregulation as well as glucose production. This is a very, very important time in a baby's life. It is important to consider two very important time periods in a newborn's life, and that is the golden minute, which is the first minute of life in which the baby has to start breathing, and then the golden hour in which the baby has to undergo all the other physiological changes to survive without the mother. It is important to remember that most babies need no assistance at birth. It's still supposed to be a joyous, happy, normal occasion. Around 10% will need some support to start breathing, just a bit of stimulation, and then less than 1% actually progress to extensive resuscitation, which implies that you will have to perform chest compressions and even give adrenaline. So it's really the minority. This will depend largely on where you are working. Obviously, if you're working in a level 2 or 3 hospital, the mothers and the babies are there for a reason, and there are often risk factors which you have to consider, and we see many more resuscitations in these situations. I just want to emphasize a few general principles. It is important to be prepared for the worst case scenario. It starts with you knowing precisely what you are going to do, to know the algorithm off by heart, and then to make sure that your equipment is present and in a working order. It is also important to make sure that help is available, especially if you know that it's going to be a complicated delivery or there are major risk factors present. And then noting the time is really important, because the whole algorithm is time-based, and it's also important to know when to stop and withdraw your resuscitation efforts. So note the time. The Helping Babies Breathe program is a training course for birth attendants on how to care for a newborn at birth. The whole idea of this global initiative is to ensure that all babies get standardized care at birth. It focuses basically on the first minute of life, the golden minute, in trying to support the newborn and to get the baby to breathe. In the first step of Helping Babies Breathe, preparations are made for the birth. It specifies that there must be a skilled birth attendant whose sole responsibility will be the newborn. She must have a helper and a plan of what to do. There should be a delivery area that is well lighted and obviously as clean and sterile as possible. There's emphasis on hand hygiene, as Neonatal sepsis is one of the big killers of our babies. And then they should have equipment available to start resuscitation and specifically to ventilate a baby. When the baby is born, there's a standardized routine care plan instituted. So as the baby is born, it's placed on the mother's legs or chest. The baby is dried and checked for crying and continuously assessed that he's breathing well. The skin-to-skin position is ideal to prevent hypothermia and to make sure that the baby is warm and comfortable. Delayed cord clamping is advised, so anything from 30 seconds to 2 minutes or until the cord looks snow white and stops pulsating is acceptable. Then the baby is also in an ideal position to resume early breastfeeding, which will aim to prevent hypoglycemia. During standard care, the algorithm will be here in the green block. But as soon as the baby is not crying well or not breathing well, they will progress to the orange side, the danger signs. In this instance, they will place the head of the baby in a neutral position and clear the airway. The baby will be stimulated to get the baby to breathe, and then evaluation will take place, and if the baby is not responding, ventilation with an ambibag will be started. If the baby's been ventilated but does not respond to positive pressure ventilation, with other words, the baby remains bradycardic, the algorithm calls for help with emphasis on improving the ventilation strategies, but there must be an emergency plan in order for the midwife to access advanced care for the newborn patient. During this time, the warmth of the baby has to be maintained and ventilation continue during transport. The support of the family is important because obviously things are not going according to plan and the baby will now need to be transferred to a higher level of care. It must be clear from the first few slides that the Helping Babies Breathe program is actually designed to fit in with the advanced neonatal life support. So that's the basis on which you start on. If the baby then doesn't respond, we will go to advanced care, but you'll see that the principles are precisely the same. The algorithm regarding neonatal resuscitation has not changed from the ABC to the CAB method that we use in children and adults. And the reason for that is that neonates are very much different from children and adults. They are growing in an oxygen-deprived environment, and if you could put a SATS probe on a fetus in utero, the SATS would only be 40 to 60%. Therefore, breathing is emphasized because they need to oxygenate for all the other systems to stabilize. So we're always going to focus on the airway stabilizing and assessing of a patient, followed by breathing and supporting the baby's respiratory efforts. Only then will we consider circulation and chest compressions if the heart rate does not pick up. Then D for drugs. And in the end, you have to make a decision on how to go forward and what to do with the baby next. When you attend the birth of a baby, it's important to take note of the maternal history, the history regarding risk factors for the pregnancy, the gestational age, etc. All of that should be noted in the admission book or neonatal record book. However, when you're standing with a baby in your hands, you need to ask 3 basic questions. Is the baby term? Is the baby breathing or crying? And does the baby have good muscle tone? If the answer to the 3 questions are yes, with other words, it's a term baby who comes out kicking and screaming, then you know that the baby is going to do well, and then you will institute Helping Babies Breathe and do routine care. So it's important to try and keep the mother and the baby together, and for the baby to make the transition on the mother's chest. As you can see in the photo, the baby still has acrocyanosis, the lips are blue, which is a sign of peripheral cyanosis, but the baby is left with the mother as the baby is breathing well and now making the transition successfully. Unfortunately, not all deliveries go according to plan. In the sensitive Caesar, the father is now used to place the baby in a kangaroo position while the mother undergoes her operation and her post-operative care. So it's important to try and keep the family together. Some of the challenges in keeping the mother and the baby together during this transitional time is actually with the medical team. So we want to weigh the babies, measure the babies, make sure that they are okay. And we often take babies from the mothers, which can negatively influence the baby's transition, causing hypothermia, hypoglycemia, and late initiation of breastfeeding. If one of the questions have a negative answer, the baby is either preterm and or is not breathing well and or is hypotonic, then you need to follow the advanced resuscitation algorithm. Firstly, we are going to emphasize the importance of the airway and stabilizing procedures, after which we will assess the baby. For this step, you have about 30 seconds, keeping in mind that we are aiming to get the baby breathing within the first golden minute of life. In the first step, we're going to ensure that the baby remains warm during the resuscitation attempt. So firstly, the room temperature should be at around 24 to 26 degrees Celsius. The baby care center and the radiant heater should be switched on well in advance of the delivery so that all the towels that you are working on are pre-warmed. It is important to note that especially preterm babies have increased morbidity and mortality if they become hypothermic. So it's something to focus on and to make sure that you get right from the very start. As you put the baby under the radiant heater, you must place the head in a neutral position in order to open up the airway and enable the baby to breathe with ease. Because of the very prominent occiput of the baby, they tend to flex their airways and then they cannot breathe properly. To relieve this problem, you can put a towel, fold it to 2 to 3 centimeters under the baby's shoulders and let the head fall back naturally. This is also the best position for you when the baby needs intubation. Once the airway is in a neutral position, you can now clear the airway by suctioning first the mouth and then the nose of the baby. This step has been de-emphasized in the newest guidelines, and you only need to suction if you think that the secretions are posing a problem. So overseas they use the bulb suction, which is a good device because it is gentle on the tissues and you can't insert it too deeply. The wall suction that we use, we need to use gentle suctioning, and remember not to insert the suctioning tubing too deeply because it can cause damage as well as vagal stimulation, which will lead to apnea, bradycardia, and laryngospasm, which is precisely what you are trying to avoid at this point. Now that the airway is in an open position and clear, you are going to dry the baby with a pre-warmed towel. There are two reasons for this. The first reason is that you are going to dry the baby to prevent further heat loss from evaporation. And the second reason is that with drying the baby, you are also stimulating the baby to start breathing. Once you have dried the baby, you can also perform gentle tactile stimulation by rubbing the baby's body or turning the baby on the side to rub the back. You may also flick or tap the feet, but remember not to hit the feet, as this can injure the baby. If you have changed the baby's position, then reposition the baby in an optimal position. It is important to realize that you may never pick the baby up by the feet. Remember that the blood pressure to the baby's brain is not well regulated in the neonatal period, and especially preterm babies are pressure passive, which means that if you pick them up by the feet, all the blood rushes to the brain, which can cause an intraventricular hemorrhage. There are two exceptions in the first 30 seconds of life. In the first one, the premature baby of less than 29 weeks or 1.5 kilograms will become hypothermic despite your best efforts. They found that when you wrap the body of the premature baby in plastic and put them under the radiant heater, they tend to maintain their body heat better. So it's important to not dry the baby, especially in the extremely low birth weight babies. You can injure the skin when drying them with a towel. So you will wrap the body in the plastic and put the baby under the radiant heater. You may dry off the head and cover it with a woolen cap, and then you can monitor the baby's temperature. The second exception is for full or near-term babies with hypoxic ischemic encephalopathy. It has been shown that these babies suffering hypothermia might actually worsen their neurodevelopmental outcome. The question here should be, should I switch the radiant heater off? It's important that if you do, to monitor the baby's temperature and not overcool them, as severe hypothermia will also be bad for the baby's neurological outcome. It is important to remember that babies with moderate hypoxic ischemic encephalopathy may qualify for therapeutic hypothermia, which is a very specific management strategy in order to protect the baby's neurodevelopmental outcome. The baby should qualify by checking the inclusion criteria, and the treatment has to start within 6 hours. Otherwise, the damage has already been done. So the critical machine is the one in the picture. Is started within 6 hours. The baby's core temperature is cooled down to 33.5 degrees, which will be continued for 72 hours, after which gradual rewarming will take place. I'm sure that when you look at last year's notes, you will notice that all the mechanisms of heat loss that we talked about, namely radiation, conduction, evaporation, and convection, is taken into account in the first 30 seconds of the baby's life. At the end of the 30 seconds, it's important to assess your patient. So firstly, it's easy to see if a baby is breathing, crying actively. You must check the heart rate. It's often easiest to check for the heart rate, feeling for the pulsations on the umbilical cord. If you're unsure about the cord pulsations, you may use your stethoscope to listen to the baby's heartbeat. And in the new guidelines, they actually suggest that you put the baby on an ECG monitor, which is difficult for us due to resource constraints. The heart rate must be counted for 6 seconds, and then you can just add a 0 to get the rate per minute. Don't spend too much time on this. If the heart rate is more than 100, you know the baby's doing well. However, if the heart rate is slow and less than 100, you need to progress to the next step as soon as possible. So let's first focus on what is normal. You expect the baby to have a good strong cry with good respiratory effort and breathing at around 40 to 60 breaths per minute. The pulse rate should be around 100 beats per minute, and the baby should have a blue color at this point. You may have been a little surprised at the baby being blue and it being normal, but remember that the fetal saturations are between 40 and 60% before the baby is born. You can imagine that with a difficult birthing process, it might even be lower than that. At 1 minute after birth, the targeted pre-ductal saturation of a normal infant can be expected to be between 60 and 65%. By 5 minutes, the baby should pink up and the SATs will be at 80 to 85%, and by 10 minutes, the SATs should be around 90%. It's important to realize that the post-ductal SATs can take up to an hour to reach these values, so always put the probe on the right hand of a newly born baby. So if the baby is breathing, the pulse rate is more than 100, but the baby looks blue, don't be too stressed. If you wonder what is going on, check the preductal SATs and then check whether the baby is making the transition. If the baby is more cyanosed than you would expect, supplemental free flow oxygen can be administered. If, however, things are not going well and the baby has apnea or gasping respiration, and or the pulse is less than 100 per minute, and or the baby is persistently cyanosed with SATs lower than the targeted SATs, then you have to support the baby's breathing and progress to the next step. So at this point, you will call out to the theatre that you are starting positive pressure ventilation. For this step, you will have approximately 30 seconds. Remember, we're still focusing on the golden minute. When supporting the baby's breathing, you will start with positive pressure ventilation at a normal rate of 40 to 60 breaths per minute. Take note that the inspiratory time of a baby is very short, 0.35 seconds. And for that reason, you have to count a very specific way to remind you to keep this inspiratory time short. So the breathing count is like the waltz. Breathe, 2, 3, breathe, 2, 3, breathe, 2, 3. Studies have shown that in order to open up a newborn baby's lungs, you will need positive inspiratory pressures of around 20 to 30 centimeters of water and positive end expiratory pressure to prevent atelectasis at 2 to 5 centimeters of water. Remember that although preterm babies may need respiratory support more often, they have very small and easily damaged lungs. So do not overinflate their lungs, limit your pressures and your volume, and check the chest expansion in order not to overventilate them. The success of positive pressure ventilation is highly dependent on the seal of the mask on the baby's face. In the correct position, the nose and the mouth of the baby will be included in the mask. If the mask is too small, the baby's lungs will not inflate, and in the larger mask, you can actually even cause damage to the eyes. So always look for the right sized mask. In order to ensure effective positive pressure ventilation, the seal of the mask is very important. I suggest the easy clamp method, with which you take your thumb and forefinger, create a C and press down on the round mask firmly so that there's no leakage of air around the mask. With the other fingers, you can make an E by putting the fingers on the bony part of the baby's jaw and not over the airway, as it can easily obstruct the trachea. To support the baby's breathing effort, you have two choices. You can either use a self-inflating infant resuscitation bag, better known as the ambu bag, or you can use the T-piece ventilator or the new puff. Each device has its own advantages and disadvantages. So just starting off with the ambu bag, this is a true ambu bag. All the devices have the same features in that they can self-inflate after you have delivered your positive pressure breath by pushing on the bag part of the device. So the first advantage is that you can immediately grab this device and immediately ventilate a baby's lungs. You do not have to set it up, you don't have to calibrate it, you can immediately use it. The disadvantages, however, is that it can be very dangerous in untrained hands. You can cause barotrauma by exceeding the 20 to 30 centimeter water guideline, as the pop-off valve will only pop off at around 40 centimeters of water. At the end of your breath, the pressures will fall to 0 unless you have a PEEP cap, and this is also a disadvantage, especially in preterm babies who tend to have atelectasis of their alveoli, especially in the face of hyaline membrane disease or respiratory distress syndrome. The bag can allow you to give 100% oxygen by utilizing the reservoir tube or reservoir bag. It will fill with 100% oxygen when you have 100% oxygen connected to the oxygen port. 100% will then fill the reservoir tube, and there will be 100% in the bag area. For that reason, you will be ventilating with 100%. If, however, 100% oxygen is administered, but the reservoir tube is left off, it will suck in room air, and therefore you will be ventilating with 40 to 60% oxygen, depending on the flow. Obviously, you may use the device without any oxygen attached, which is one of the advantages, and then you can start ventilating with room air. In order to make the self-inflating resuscitation bag safer, there are two devices that you can add. The manometer, that will enable you to see the amount of pressure that you're exerting on the lungs, and then the PEEP valve that will ensure that not all the air leaves the baby's lungs, that some is held back to promote good extension of the baby's lungs. If you do have a choice, it's best to use the T-piece ventilator or the new puff. There are many other devices on the market at the moment. It can either be built into the resuscitation center, or it can be a mobile device that you can carry around. So the first disadvantage of this device is that you have to have flow to make it work, and you have to calibrate it before you can use it. So in the green piping, you'll see that there's written gas inlet, and that is where you will attach the flow from a flow meter at around 5 to 15 liters per minute. On the manometer, you will be able to see the pressures that you're exerting on the baby's lungs. You have the inspiratory pressure control valve that you can set your peak inspiratory pressures with. Then you have the patient circuit, at which point you will attach the right sized mask, and just above it is the little white PEEP cap with a plus and a minus on it, where you will set your positive end expiratory pressure. So in order to set up this device, you will set the flow at, let's say, 10 liters per minute. You will occlude the front part of the patient's circuit totally with your finger and see the dial needle moving towards your positive end expiratory pressure reading. So if you want to change the PEEP, you will turn the PEEP cap to the plus or minus side, and we are going to set it at 2 to 5 centimeters of water. To set your peak inspiratory pressure, you will occlude the front part of the patient's circuit and put your finger on the PEEP valve. That aperture hole will then release flow from the ventilator, and that will give you your peak inspiratory pressure, which you can set as explained. Here you will set it at 20 to 30 centimeters of water. With a T-piece ventilator, you will give a positive pressure breath by occluding the aperture hole with your finger or thumb for an inspiratory time of around 0.35 seconds. Take care not to forget your finger on the aperture hole, because that will release flow, and it will keep on releasing flow and expanding the baby's lungs and can easily lead to a pneumothorax. So your finger must always just be on that aperture hole for the inspiratory time. The advantages are clear. You can give positive end expiratory pressure even in a spontaneously breathing baby. It can aid the baby and ease the work of breathing. You will give the same positive inspiratory pressures with every breath because it's set. You can also see on the device whether you are reaching those pressures, and then you can titrate the pressures to the effect that you want. Major disadvantage again is that you have to set this device up way before you start resuscitating, and you need all the equipment to be present. If you want to titrate the amount of oxygen, it is advised that you have an air oxygen blender. Otherwise, you will be necessitated to ventilate with 100%. So let's say you're in a small hospital that does not have medical air. You will have to attach your new puff machine to an oxygen cylinder, which obviously will give you 100% oxygen. And as we have already discussed, giving 100% oxygen can be detrimental to the patient. You actually want to start with room air. When starting your resuscitation, it's important to remember the targeted pre-ductal saturation values, which reflect the normal adaptation of a baby from intrauterine to extrauterine life. So at 1 minute, the baby will be cyanosed because the SATs will read at 60 to 65%. By 5 minutes, you expect it to pick up to 80 to 85%, and at 10 minutes, it should be around the 90s. Studies have shown that using 100% oxygen during resuscitation can actually be damaging to the baby, as it delays the onset of normal respiration, and it can cause free radicals that will damage all the membranes in the baby's body. Studies then have shown that starting with 21% is superior to using oxygen, and that if the baby then does not respond after around 90 seconds of the ventilation and resuscitation, you may then slowly titrate upwards with your oxygen to get the pulse rate above 100 per minute. So the use of pulse oximetry is mandatory. Remember to attach it preductally on the baby's right hand and not on the foot, which is postductal, and those values will only pick up to the preductal values after an hour. You can then titrate the amount of oxygen that you administer to keep the pulse rate more than 100 and to follow the targeted saturation values. Preterm babies, however, will need more respiratory support and may actually require oxygen to make this transition successfully. The guidelines state that you should start with 21 to 30% oxygen. Again, use the pulse oximeter to help you titrate the oxygen to the desired amount. The importance of this is that preterm babies have no antioxidant systems in place, and they are even more likely to suffer from free radical damage. Specifically, intraventricular hemorrhage might predispose to respiratory distress and also increase the risk for necrotizing enterocolitis. So always be very careful when titrating oxygen. We don't want to make the baby hyperoxic. After giving positive pressure ventilation for 30 seconds, it is important to reassess and evaluate the success of your resuscitation attempts. At this point, do not stop your ventilation if the baby is not yet breathing, as you will undo all the good work you've done thus far. So your helper must now check the pulse to establish whether the baby is improving or not. So if the pulse rate was 20 and now it's 40, you know you are moving in the right direction. However, if the pulse rate was 80 and now it's 40, then it means that you are doing something wrong, and then you have to advance to the next step. When you evaluate and reassess and the heart rate is more than 100, you're probably doing a good job with ventilating the baby's lungs, and the baby's probably oxygenating well. So at this point, you need to continue with supportive care, as the baby did need resuscitation and some help to start breathing. So keep observing the baby's effort and slowly withdraw your respiratory support if the baby starts to breathe spontaneously. If the heart rate remains less than 100, it is probable that the ventilation strategy is not working, and then you have to focus on correcting the mistakes by taking ventilation corrective steps. You do not have to wait for the 30 seconds of positive pressure ventilation to be over for evaluating the ventilation strategy. So your helper can immediately start using the acronym Mr. SOPA and to take corrective steps and ensure that the technique of ventilation is adequate. So because the mask is most often the problem, it is important to adjust the mask and ensure an adequate seal of the mask on the baby's face. Also ensure that the airway is in a neutral position, and if not, put a towel under the baby's shoulders and reposition. If you have not yet suctioned, ensure that there are no secretions blocking the airway by suctioning first the mouth and then the nose. You can also open the baby's mouth. This is specifically applicable to babies with upper airway obstruction, as we find in choanal atresia. At O, I also suggest you consider oxygen at this point. If the baby is not responding very well, but the chest is moving nicely, you can consider titrating the oxygen upwards to ensure that the pulse rate reaches 100 per minute. If all of these factors have been corrected, then you can increase the pressure to better inflate the lungs, especially if you cannot see good chest rise. And then the last step would be to consider an airway alternative where you would then intubate the baby. Once you've corrected the ventilation strategy, it is important to recheck the heart rate. If it remains less than 60 beats per minute, it is time to progress to the next step, which is C for chest compressions. At this point, first increase the inspiratory oxygen to 100% and then ask your helper to start chest compressions. When you start performing chest compressions, this step will take 45 to 60 seconds. The whole emphasis here is on minimal interruption, as it takes quite a few compressions for the blood to start flowing. The aim is to perfuse the myocardium by ensuring good coronary artery blood flow and also to provide blood flow to the brain to avoid hypoxic ischemic encephalopathy. Studies have shown that the two thumbs encircling hands technique is the superior technique to use for compressions in the neonate. The two-finger technique may also be used, but because of the encircling hands also causing a squeezing effect, the two-thumb technique is preferred. So you will place the two thumbs on the lower third of the baby's sternum, taking care not to press on all the ribs, but to place your fingers in such a way that you only press on the sternum. You will press 1/3 of the AP diameter in depth to ensure that you squeeze the heart between the sternum and your vertebral column at the back. The ratio of compressions to ventilation is very different from what is performed in children and adults. So in neonates, because of their relatively high respiratory and cardiovascular rate, you need to aim for 120 vents per minute by performing 3 compressions to every 1 ventilation. This will mean that a cycle of compressions and ventilations will take 2 seconds, and in the end you will be giving 90 compressions and 30 ventilations within a minute. The person doing the compressions will then count 1 and 2 and 3 and breathe, and 1 and 2 and 3 and breathe, and 1 and 2 and 3 and breathe, and take care to make it a nice steady rhythm, not too fast and not too slow, and for that reason do not forget the ands. It helps you to pace the compressions adequately. At the end of 60 seconds of chest compressions, you will reassess your patient. If the heart rate remains less than 60, it is probably not enough to maintain a stable blood pressure in the neonate. For that reason, you will now progress to D for drugs, and this will mean that you will start administering adrenaline. The preferred route for adrenaline is the intravenous route. For that to happen, you will have to insert an umbilical venous catheter to a depth of 2 to 4 centimeters and then administer the adrenaline through that line. Unfortunately, we do not have a 1 in 10,000 solution of adrenaline in South Africa. For that reason, you will have to dilute it yourself by taking 1 ml of adrenaline, which is 1 ampule, and then dilute it with 9 ml of normal saline or sterile water for injection. Of that 10 ml solution, you will then administer 0.1 to 0.3 milliliters per kilogram. You can repeat this dose every 3 to 5 minutes. In an emergency situation, if you're unable to get IV access easily, you can also give it through the endotracheal tube. Obviously, the adrenaline will have to be absorbed in the lung circulation and then still need to reach the heart to have its effect. And for that reason, you will use a higher dose of 0.5 to 1 ml per kg of the diluted solution. Very important, never to give adrenaline intramuscularly, sublingually, subcutaneously. The only acceptable routes are IV or through the endotracheal tube. If the baby is very shocked or you know that there was blood loss, for instance in a bleeding placenta previa or vasa previa, or the baby has poor perfusion, it might be necessary to give a volume expansion to ensure that the circulation of the neonate can return to normal. The appropriate fluids to use for volume expansion is isotonic crystalloids, with other words normal saline or Ringer's lactate. Please note the dose. It is 10 ml per kg and not 20 ml per kg as you would give in children. You must administer the bolus over 5 to 10 minutes to avoid swings in the baby's blood pressure. Also important, never to use dextrose-containing fluids such as Maintenalite or Neonatolite in a patient because it can worsen the neurological outcome. Do not administer the bolus too fast, especially in preterm babies that have a pressure passive circulation to the brain. It can actually elicit an intraventricular hemorrhage. Unfortunately, we do not have O-negative packed cells on standby, but if the baby has bled out, it stands to reason that you will have to replace the hemoglobin by a packed cell infusion, which you will then have to order from blood bank. Hypoglycemia remains a medical emergency. So if your patient is not responding well to your resuscitation attempt, it is important to check the glucose. If the value is less than 2.6 millimoles per liter, you can administer a 10% dextrose bolus to get back to normal glycemia and ensure that the baby has the energy to make the transition from intrauterine to extrauterine life successfully. Naloxone may be indicated in neonates where the mother received opioids before delivery. It is not indicated initially in resuscitation because of all the more important steps that have to take place to ventilate the baby's lungs and address the bradycardia. However, if the baby is not responding and you think there might be respiratory suppression because of the opioids, then you can administer the dose of 0.1 milligram per kilogram, which can be given IV or intramuscularly. Remember that an absolute contraindication for naloxone is when a mother is addicted to opioids, as the baby can have acute withdrawal response. The use of Sodabic to address the metabolic acidosis in a patient who is being resuscitated is still a very controversial issue. The only reason it has not yet been removed from the resus algorithm is that it may play a role in prolonged resuscitation where the metabolic acidosis can suppress the contractility of the heart. Remember that using Sodabic can actually be detrimental to the baby's health. It is better to treat the cause of the acidosis. So anaerobic metabolism will lead to lactic acidosis, and if you think about what you are doing during resuscitation, you're actually supporting the respiratory system by ventilating the patient's lungs, by adding oxygen, and then you're also addressing the ischemia by doing chest compressions and administering adrenaline. So it's much better to treat the cause of the acidosis and correct that. The Sodabic can actually be very dangerous as it can worsen your intracellular acidosis with the CO2 moving over membranes freely. It also causes major shifts in your electrolytes and in your fluids, so it's to be avoided. Intubation can be considered at various steps. It's important to note that if you can bag mask ventilate a patient, you don't have to be able to intubate, as you will be able to save the baby by your mask ventilation. However, the more experienced you are, the earlier you will consider intubation to enable you to prioritize the breathing step of the neonatal resuscitation algorithm. The indications for intubation is firstly when you think that meconium plug is actually obstructing the airway, you can then intubate the baby with an endotracheal tube, attach the suctioning tube to the endotracheal port, and then remove the whole endotracheal tube, trying to remove some of the thicker meconium plugs from the tracheal area below your vocal cords. If positive pressure is ineffective or prolonged, you can intubate to ensure that the air is actually going to the lungs. It will also loosen your hands to perform other tasks and to concentrate on your ventilation technique. Once you start with chest compressions, it's also helpful to have an intubated patient so that you can coordinate the chest compression to ventilation ratio properly and to ensure that the air is actually transmitted to the lungs. When you want to administer medication, and for your purposes only adrenaline may go through the endotracheal tube, you can also intubate the baby in an emergency situation for that reason. Then there are a few specific indications. If you have a baby that you know has an antenatal diagnosis of diaphragmatic hernia, for instance, you will try not to bag mask ventilate that patient, as the esophageal sphincters can be overcome, and then you will pump air into the baby's stomach and bowels, which will then worsen the compression of the already hyperplastic lungs. It is important to ensure that you have the specific equipment that is very specific to the needs of newborns. The laryngoscope specifically, you need straight blades of 0, 0, 0 or 1 size, and it's important because the airway of a neonate is different from bigger children and adults. The larynx is very high and anterior, and you cannot really see it when you are using the curved blade. Endotracheal tubes should be available in different sizes. For a full-term baby, you usually need a 3.5 internal diameter tube, and for the preterm babies of around 1 kilogram, 2.5 millimeter tube, and for bigger babies of around 1.5, you can use a 3. The McGill's forceps we use in nasotracheal intubation to just grasp the end of the endotracheal tube and help you to advance it through the vocal cords because of the abnormal angle. If you go orotracheally, the endotracheal tube has a natural curve so that it's easy to advance through the vocal cords, and you will not need the McGill's forceps for that reason. The nasogastric tube is highlighted. Remember that after you've ventilated with a mask, you are blowing air into the baby's stomach, and at some point it will arrest the diaphragmatic movement and cause poor inflation of the baby's lungs. So remember to insert a nasogastric tube and aspirate air from the baby's stomach. Suction should always be in a good working order, as it can be quite difficult to see the vocal cords in the presence of all the secretions. And then if you come across an introducer, it is usually used for difficult airways. Make sure that the introducer does not extend beyond the end of your endotracheal tube. It is usually made of metal or strong plastic so that you can actually lacerate the baby's larynx. So always be careful when you use that equipment. Please limit your attempt for intubation to 20 to 30 seconds. It is important to check on the baby during your attempt and ensure that the baby's heart rate remains stable. If the heart rate should drop or the saturations drop significantly, then you need to stop what you are doing and re-ventilate with 100% oxygen and hyperoxygenate the baby before your second attempt. Usually once you have seen the airway, then it's easier on the second attempt because you know the anatomy. And obviously call for help when you are struggling. It may be a quite difficult intubation in the smaller babies. Just a reminder of the anatomy. So you have the tongue, then the epiglottis, with your vocal cords hiding behind your epiglottis. In adults, you will usually put the tip of the blade of the laryngoscope in front of the epiglottis and pull in the direction of the handle. But in preterm babies and term babies, it might be easier to take the tip of the straight blade, slide it over the tongue, and as you slowly withdraw it, you will see the epiglottis pop out. Then you know where you are. So then you can put the tip of the blade behind the epiglottis, lift it out of the way, and then you will see the 2 vocal cords. So you should actually see those 2 stripes. If it's just a big black hole, that is probably the esophagus, and you need to again reposition and see if you can see the vocal cords. They may even be moving. If you are inexperienced, rather use the orotracheal route. And to check on the position of your endotracheal tube, you actually want to see the tip of the tube advance through the vocal cords. So your bradycardia will respond immediately. You will see symmetrical chest movement. You will check the saturations, which will increase, and the baby will pink up. You can auscultate both lungs and over the stomach area to ensure that the tube is in the right place, and also to compare the 2 lung inflations to make sure that the tube is not too deep and just ventilating one lung. If you are working in a developed country, you will have access to a capnograph where you can actually see the CO2 that is coming back from your endotracheal tube, and then you will know that you are in the right space. But unfortunately, we do not have that available in most of our state institutions. Don't be afraid of intubation. You can intubate just about anything, but please make sure that you take the correct steps and that you monitor the baby very carefully during your procedure. Don't use excessive force. If you injure the mucosa, it really can bleed quite a lot, which will make it very difficult for you to intubate. So always be very gentle with babies, and you should be successful. All pediatricians have a healthy respect for meconium aspiration syndrome. So it's a condition that you must know, and that you must know how to manage correctly from the start. Babies who pass meconium in their amniotic fluid are usually of term or post-term gestational age, and it's a reflection usually of fetal distress, apart from babies who are born breech, and they may pass meconium for other reasons. But it usually indicates that a baby was compromised in utero, which will probably lead to a cesarean section and a resuscitation at birth. Intrapartum suctioning was performed previously but is no longer recommended, as it does not decrease the incidence or the severity of meconium aspiration syndrome. So what they used to do is to deliver the head of the baby, then suction the upper airways before delivering the rest of the body. So obviously this leads to a delay and is no longer performed. Tracheal suctioning is only performed if there are signs of tracheal obstruction by a meconium plug. Since 2015, no routine suctioning below the vocal cords have been advised. So this change in practice took place because there was very little evidence of benefit, and there was actually significant harm due to delay of normal resuscitation measures, as the people tried to intubate and then suction below the cords, and in that time the baby was then starved of oxygen. So this is no longer being done, so only suction if you cannot inflate the lungs. Babies with meconium aspiration syndrome have a significant risk of morbidity and mortality, and what is most worrying is persistent fetal circulation due to poor oxygenation because of the aspiration of meconium. So if there's any doubt, if the baby has any signs of respiratory distress, rather admit them for observation and administer oxygen to maintain the SATs between 90 and even 95 to ensure that the fetal circulation does not persist. After 10 minutes of resuscitation effort, it is important to re-evaluate and decide on what to do next. So if there are no signs of life at the onset of resuscitation, and after a good resuscitation effort of around 10 minutes, there is still no sign of life, the risks for mortality or severe neurodevelopmental disability is so high that guidelines state that you can then withdraw your resuscitation attempt. However, if there is a poor response after 20 minutes, you may also decide to withdraw. This is a bit more tricky. Examples would be in a low resource setting that if the baby has no breathing effort, it implies that the brainstem is so damaged that the baby cannot even initiate his own breathing. Therefore, you can then withdraw. Another example would be if you give adrenaline and the pulse rate picks up, but then it drops again and the bradycardia takes longer to respond to a follow-up dose of adrenaline. That baby is just not responding well to resuscitation and is likely to have a very poor outcome. Withholding neonatal resuscitation can be a very difficult situation. In developed countries, the borders of viability is around 24 to 26 weeks, and birth weight of ranging between 4 and 500 grams. However, in a resource-constrained setting, as we are experiencing in South Africa, we do have to keep the principle of justice in mind. So for us, we will definitely prioritize babies of 28 weeks or 1,000 grams and above. However, we do make some exceptions for babies between 27, 28 weeks and between 8 to 900 grams and 1,000 grams. If congenital anomalies are present that will lead to early death or severe morbidity, you do not have to resuscitate those babies, and you can withhold your resuscitation. Examples would include severe hydrocephalus with very little cortex of the brain present, and encephalic babies usually only survive for 3 to 4 weeks, if that long, and therefore you do not have to resuscitate them. And then babies with proven trisomy 13 or 18, you can just do the basics and give supportive care, and you don't have to do intensive neonatal resuscitation. However, not all babies with cleft lips have trisomy 13, so if you are in any doubt about the prognosis, rather resuscitate, and you can always redirect care once the baby has stabilized and have been sorted out, especially also giving you time to consult with the parents. There's a whole new move in neonatal resuscitation, and that is to look at behavioral skills, focusing on working as a group towards a common goal. So it's important that there should be a leader of the resuscitation team, and the team should work very well together with efficient communication, and everybody should know what the other people are doing. There should be professional behavior. So remember, this is one instance where the parents, or especially the mother, cannot leave the room while you are resuscitating her baby. So to remain calm and professional at all times is very important. Also make sure that you call for help when needed and elicit the help of more senior doctors if you are in a difficult situation. You should make sure that you are trained well and that you keep up to date with the newest guidelines regarding neonatal resuscitation. Debriefing is often neglected, and it's really important to talk after a neonatal resuscitation to decide where things went wrong. Is there anything in the system that you can change, and can you avoid problems in future? In all of this, please do not forget the parents. It's really important to clearly and honestly communicate with them about what is happening to their baby, about what you are doing, and what the outcome is going to be. You should always show and feel empathy. Remember that they will be dealing with the results of your resuscitation for the rest of their lives, be it a good outcome or a poor outcome. So it's really important to make sure you do the best possible job and that you show empathy to the parents who are in a very stressful situation. Especially if things go wrong, allow them to see the baby, hold the baby, take photos. Remember that they only have one chance to do this right. A memory box might be a good idea. They have so little to grieve with that it's important to take a lock of hair, a footprint, whatever the parents need in order to help them during their time of grief. And then the support that they need. So we often make allowance for the family to visit, for church members to come. So offer them the support that they need, maybe to talk to a social worker or a psychologist. One mother wrote, "It's not the length of the gestation, it's the extent of the attachment." So do remember that parents bond with their babies much sooner these days because of antenatal sonar, knowing the sex of the baby, etc. So every family will be different, and allow for that when you are counseling parents, and try and gauge their response and how you can be helpful to them in their specific situation. So let's just summarize by just putting things in a little bit of a different light. So remember that you can work in different kitchens. It can be a very beautiful movie star suite for resuscitation, or it could be the cold realities of theatre, not fitting in with a mother's birth plan at all, which can be very stressful in itself. And obviously we do not want to land in a situation where babies have to fend for themselves. So it's always important to make sure that the environment and the people attending to our newborns are adequately trained and equipped to do so. Make sure that you have the right tools and equipment. You know how difficult it is in the kitchen when you do not have the right set of knives or the right baking pan. Make sure that you have everything that you need and that it is tailor-made for the needs of a neonatal baby. You are the cook in the kitchen, so remember to be prepared by having the knowledge of precisely what you are going to do. Make sure that you check your equipment before you start the onset of your resuscitation, and you must be ready for any and every eventuality in order to make sure that you have a good outcome for your patient. The recipe has been worked out and it's easy. Remember, in the first minute of life to focus on the golden minute and to get the baby adequately breathing. After that, you can focus on circulation, by allowing a little bit more time for compressions, and then to assess every 30 to 60 seconds afterwards to see if the baby needs drugs, specifically adrenaline, and then at E to decide when to finish in the kitchen, so when to stop your resuscitation. 10 minutes if there's no sign of life, or 20 minutes you can withdraw your resuscitation attempt if there's a poor response. Or if the baby is responding well, then you must make a decision on where you will admit the baby, or if it is safe to send the baby to the mother. So just a few pressure points. With other words, things that if you don't do it right, it can actually be detrimental to your neonatal resuscitation attempt. Remember that newborns are poorly equipped to maintain their body heat, especially after being born. So keep the baby warm at all times. This is specifically important for preterm babies who will suffer increased morbidity and mortality if they become hypothermic. So make sure that you maintain their body heat. There are two exceptions. So the first is a premature baby weighing less than 1.5 kilograms, around 29 weeks. In those patients, you can wrap the body of the baby in plastic without drying the baby first and put the baby under the radiant heater. Never wrap a baby in layers and layers of blankets. He will just become cold inside because he needs that external heat source. The other exception is when you have a near-term or term asphyxiated patient. You must rather keep the baby on the cooler side. Hypothermia will worsen the brain damage, and you will have to reevaluate and classify the baby to see if he qualifies for therapeutic hypothermia. The next important pressure point is to get the baby to breathe. So the first instance, you will provide gentle tactile stimulation so that the baby can start breathing. If the baby is not breathing after stimulation, then you will have to start with positive pressure ventilation. It's important to remember not to do harm. So minimize barotrauma, volley trauma, and atelecto trauma by using the T-piece ventilator if available. Also ensure that you don't give your ventilations too fast or too slow, as hypo and hypocarbia is associated with its own problems. In hypocarbia, if you overventilate the baby, the CO2 can drop, which will cause vasoconstriction in the baby's brain, and especially in preterm babies, it can lead to intraventricular hemorrhage and periventricular leukomalacia. So to avoid that is important. As ventilation is the most important step, it's important to take corrective steps to ensure that the baby is properly ventilated. So if the heart rate remains less than 100, remember to go through Mr. SOPA, and then to also consider administering oxygen. And you can slowly titrate upwards from the 21% up to 40 or 50% and check the saturations to make sure of the response. Avoiding hyperoxia and hypoxia is important. So use a SATS monitor, obviously putting it on the right hand to monitor the preductal saturation according to the guidelines. It is important to use an air oxygen blender so that you can blend the oxygen and give anything from 21 to 100% oxygen. And then you must use targeted SATs according to the guidelines, and after 10 minutes you can aim for 90 to 94%. Just again to emphasize that term babies, you must start your resuscitation on room air or 21% oxygen, but preterm babies might need a little bit higher oxygen to make the transition, so 21 to 30% is applicable to them. Once you've optimized the breathing of the patient and the pulse rate still remains less than 60, remember to increase the oxygen to 100% and then start cardiac compressions. The ratio of cardiac compressions to ventilations will always be 3:1, even if the baby has been intubated. The mantra is push hard, push fast with minimal interruptions. Also note in the picture the perpendicular placing of the thumbs on the baby's sternum in order to push the heart between the sternum and the vertebral column and not to push against the ribs of the baby. If after 60 seconds the heart rate remains less than 60, you can administer adrenaline. The preferred route is intravenous. You will have to mix the adrenaline yourself to get to a 1 in 10,000 solution, and of that you can give 0.1 to 0.3 mils per kg. The umbilical line should be inserted to a depth of only 2 to 4 centimeters in the emergency situation to make sure that it's correctly placed. But if you are unable to get up a line or IV drip, you can then use the endotracheal route. However, you need to use a higher dose. You can intubate a neonate at various time periods during your resuscitation algorithm. Be sure to evaluate your patient during the procedure to avoid severe hypoxia and bradycardia. Remember that babies born through meconium-stained liquor, no intrapartum or tracheal suctioning is indicated. You will manage the baby like any other, putting the baby under the radiant heater with the head in a neutral position. You can suction meconium from the oropharynx by firstly suctioning the mouth and then the nose of the baby. You will then stimulate the baby to see if the baby will breathe, and if not, you will start with positive pressure ventilation. So even if a baby is non-vigorous, you do all the normal steps, and it's only if the baby has a blockage of meconium in the trachea that you will intubate to suction below the vocal cords. When should you get out of the kitchen? So if there are 10 minutes of no sign of life, you can stop. And if there are 20 minutes with poor response, please make sure that you consult a senior colleague to decide on the further course of management. Your sous chef, with other words, the rest of the team, make sure that you communicate clearly, that everybody works together, and that you help each other and communicate about what you are seeing, experiencing, and any further suggestions. Remember to consider the parents during this very stressful time and to give them the empathy and support that they need to get through this very sad occasion in their lives. Document everything you tell them and make sure that they understand what happened, and give them the chance to ask questions, and a follow-up appointment is advisable, especially if you request a post-mortem.